this on YouTube because I really hope it goes viral. No, I don't hope any of those things.
Main Street.
No. The first thing, I'm Leah Carlburg. I know a lot of faces here. I'm a physician with geriatrics and supportive care. I'm a family medicine trained physician in the beginning of my career, and then I also boarded in hospice and palliative medicine. So the first thing I'm going to say is, in palliative medicine, people and families are first, and so I say that because my husband has to drop my kids off like halfway through this. So if they come in, just, life is messy. Oh, shoot, okay.
That way we can get you on the recording.
Okay, I'm going to walk around still.
You could maybe hold it.
Okay. We will see what happens. We are here to talk about Palliative Care 101, and I want to make sure you guys know this is informal. There are questions. This brings up a lot of professional feelings. It brings up a lot of personal feelings. There is a lot of questions around where we draw lines and how we draw them and what it all means. So please raise hands, shout out. This is pretty informal and meant to be, at best, a discussion, because information going this way is not always the best way to help people understand. Usually information going at least two ways is the best way to help people understand things. So there's a lot of words up there, and you all know how to read, so I'm not going to read them, but I'm going to point out a couple things that are important. This is the definition of palliative care from the World Health Organization. We tend to think it's only us in America that don't admit that we're going to die someday, but this is a worldwide problem. The thing that I think was important in this one is that quality of life, patients and families, life-threatening illness, prevention and relief of suffering. I always thought this was kind of tough. Impeccable assessment and treatment of pain. I always sort of felt like that was heavy. I'm like, oh, I have to be like impeccable. It's not like halfway decent or, not bad assessment of pain, and but no, impeccable, says the World Health Organization. So treatment of pain and other problems, physical, psychosocial, and spiritual. So to me, the important things are patients and families, life-threatening illness. Note that it doesn't mean 3 days before death. Relief of suffering, pain and other problems, physical, psychosocial, and spiritual. This is the definition from the Center to Advance Palliative Care. They have done amazing work in helping people in the field. And so I think the things in this one that are important, that are different, are that it is a medical and nursing specialty. So it's a specialty field in medicine and nursing, like cardiology, like oncology, focused on maximizing quality of life during any and all stages of serious illness. So life-limiting illness, terminal illness, vocabulary is different, but it's not, limited. It's life-limiting or serious illness. So specialized medical care, again, relief from symptoms and stress of serious illness with the goal to improve quality of life for both patient and family, appropriate at any age and any stage, and provided along with curative, spelled that wrong, and life-prolonging treatment in any care setting. So that's hard for us to understand because in the United States, the way that care was provided for people who were very sick and terminal, to use one word, was hospice. And hospice in the United States is paid for on a you can have this but you can't have this model. It's a you have to cross a line and say I'm choosing only comfort, and then you choose not to have other things. So that's why it's hard for us to wrap our brains around treating the whole family and the whole person at all stages of their disease. So this is my own way that I talk to patients and families about it. Because it's hard to explain what it is that we do. My oldest daughter says it's a lot of yada yada, a lot of blah blah blah. I don't talk about palliative care with her, but like when I talk at her for a long period of time, that's what she says. And it is a lot of talking. But I say you have specialists for different problems in different organs, and we're the specialists that are concerned with the human being and the family attached to those organs. So I'm not an oncologist, but my job is pain, stress, suffering, communication. We'll get more into that. We like to say that just like a gastroenterologist procedure is a colonoscopy, our procedure is a family meeting. Sometimes only slightly less uncomfortable without the sedation. But when you think about the skill set to do a colonoscopy or the skill set to do a heart cath, that is learned, that is processed, that is sanctioned by a specialty group to say this is something you can do. And palliative medicine is the same. To run a family meeting full of cousins, uncles, the neighbor lady from down the street who always has the most opinions, and the daughter from California, and the patient to say, what does everybody understand? What do you all want? What do you think you want? What do you understand? What do we understand? That is our procedure, and that's what we do. So the other way when I talk about palliative medicine to people or palliative care is information. We want to help you understand, you as a patient and family, understand everything we understand. Meaning that patient where you go in and talk to the family, go out to the nurse's station and say, this is not going to go well. I believe that patient and that family deserves to know that. Even if it's hard to communicate with them, our job is to help people understand that the people who have seen this before are out there saying, this may not go well. There's ways to do that, and there's ways to respect people's wishes to know and wishes not to know. That's a big part of what we do. So we want to have people have the best day possible today. So we help with pain, nausea, constipation. You guys know, I talk to people in the community, nobody understands how bad constipation is. Constipation will land you in the emergency room. Constipation is a really big deal. It can really harsh your day. So we talk a lot about constipation. We want to understand who people are so we can help them have what they want and avoid what they don't want. So another terminology that's helpful for me is extra layer of support. I'm going to go back a little bit. So palliative care is and, not or. So whereas hospice, and we'll talk about that, because of the way it's paid for, is often seen as or, palliative care is and. So these are the 4 things that a palliative care team works on. And when I say team, we have 4 physicians now working in various amounts. We have a nurse practitioner who works on our team, who's amazing. We ideally have a full interdisciplinary team, which includes a chaplain, a social worker / counselor, and other ancillary services. We don't yet have that here, but a true interdisciplinary team in palliative medicine is all of those disciplines. But these are the 4 things we work on. So we work on pain and symptom management, and to me, it goes in this order. So you can't get to advanced care planning when someone is in horrible pain. You just can't, there's no way. And it's not appropriate to. Someone is struggling with bone pain from cancer, they're not going to want to talk to you about their code status until they feel better and until they're in a place where they can wrap their brain around that. So our specialties and our what we deal with is pain and symptom management, and often that's where we're really useful in a very beginning fundamental way for people. That's kind of the way we help people get to know us and we get to know them, is working with them through symptom management. prognostic awareness, is that a term you guys have heard before? So prognostic awareness is they understand what we on their medical team understand. My very first question, once we get pain and symptoms, once everybody's pooped and has their pain controlled, which sometimes takes a little bit of time, is I say, what do you understand about what's going on? Because in medicine, and you guys know this better than anyone, doctors talk a lot at people. They don't listen so well this way. And so we give information this way, and we assume they understand everything that we're saying, when there's a lot of nodding and smiling, and probably not a lot of real understanding. And maybe a difficulty in asking questions, because there may be a big difference between what they understand and what we understand. And then there's an even bigger difference between what they understand and what we think they understand. So that scenario where I don't understand why this patient and this family are choosing full code or doing antibiotics or X, Y, and Z, may be just that that patient and that family think that if they get on the other side of this, they're smooth sailing. Whereas we understand that it's unlikely that they're going to get on the other side of this. So if we could both understand that worry, then the decision making may make more sense if we all understand the same thing. Understanding we can't predict the future, and we'll get to that a little bit. So prognostic awareness is the idea that we all understand the same possibilities. Now, there also is a lot of discussion about, well, they haven't really accepted it. Like, the patient and the family are accepting, or they're okay, or they're on board, or they're whatever about that they're very sick and their time may be short. That's not a linear process. It's not like words are spoken in their presence, they get it, and then they make decisions that flow from that. It's usually words are spoken in their presence, meaning we may not have any more chemotherapy, we may not have any more treatments for your COPD or treatments for your heart failure, and then they kind of hear that, but they don't really hear that, and then something happens where their bodies tell them more about what's happening, and then they say, well, I don't think this is going that well, and then maybe you circle back here, but it's like this way. It's like I'm there and I'm not, I'm there and I'm not, and then I'm kind of there, but I really don't want to be there. And so that's not linear. So when people say we told them or they told them, it's not a one-time thing. It takes time, and it takes the patient and the family's own body telling them for them to really kind of integrate it and understand and move on. Now, that's not true of everybody, like everything. I had one patient in my family medicine days who was, 80-year-old rancher. He came in because he kind of felt something in his belly when he moved around, and he had a liver full of colon mets. No pain, had lost a little bit of weight, was kind of okay with that because he always felt like he was a little on the overweight side. And he went from, we did a CAT scan, and I went from, you have metastatic cancer, I think you need to see a cancer doctor, and I think we need to think about that. And he's like, nope, I like hospice. My mom had hospice, or my wife had hospice. That's what I want. And that was like that. Now that's an outlier, and that's why I remember it 12 years later. But everyone's different, but knowing that it's not, they're not in denial if they don't go from this is not going well to do nothing. You know what I mean? To do nothing. That's not denial, that's just process. Sorry. So we get pain control, everyone's pooping, pain is okay, family's there, prognostic awareness happens. What do you understand? They either say, they give me indications that they understand what we understand, or we start with, how do we help you understand what we understand? Also knowing that I don't tell people things that they don't want to hear unless they tell me they're okay with it. So what that looks like is daughter asks, well, how much time has he got? I'll say, does everyone in this room want to hear that? Or is everyone okay in this room hearing that? Because some people don't want to. And it's not my job to tell them if they don't want to. If they want to, then we go there. If they don't, we get to how we make decisions without that timeline. Because we suck at timelines. I've been doing this a long time. I feel like it's a long time. And it is very hard to predict someone's time. And so I tell them a range if they want to hear it, with the caveat of nobody knows your time. You know, and if they're spiritual people or faithful people, I'm like, God knows your time. My job is not to tell you your time. My job is to tell you what I'm worried about and how do we plan for what we worry about while we still hope for what we hope for. So prognostic awareness is in place, then we go to advanced care planning. Some people call it goals of care. I never really thought that was useful because, like, what are your goals of care? Well, I want to get better. Of course I want to get better. That's my goal. I think that's sort of dumb. So advanced care planning, knowing what we know about what we worry about and knowing what we know about what we're hoping for, how do we plan for if it goes the way we don't want? Without this idea of they have to be accepting and we have to stamp out all hope for them to be reasonable. It's not that way. I have never seen that to be very useful. Hope and worry live together. They always live together. We're human beings, and that's normal, that's healthy, and the fact that someone is hoping doesn't mean they're not accepting or that they are in denial. It's normal. But we don't also have to live in this only positivity world that doesn't acknowledge what we worry about. So if we say, hope and worry live together, let's plan for what we worry about. At the same time, we still have this hope for what may or may not happen.
Seems like hope could be in a smaller package. You don't hope for a cure, but you might hope for no pain.
Sure.
Or
Yeah.
hope that you make it 3 months instead
Right.
of...
So what you hope for changes. But I have to say, and you guys have seen this as well, even in that place of the person who is a day away or 2 days away or hours away, there's still that little piece of them inside that just hopes this wasn't happening. Like, hopes this will all go away. Not everybody, but some people. And I think in my training, those people were always sort of written off as unreasonable or in denial. And I don't really find that terminology useful. Like, they are where they are, and hope is fragile, but it's super powerful. So sometimes people can shift to, I am hoping for pain control, I'm hoping to get home, I'm hoping to take a big poop, like, I'm hoping, yeah, right. And some people will always have that sort of little nugget of like, maybe this will just all go away, and that's okay too.
miracle.
Yeah, there's nothing wrong with that. What we lose opportunity in is when we only go there and lose opportunity to think about what might happen and use the time that you've got to do things that allow you to have peace. So when we only live in the like positivity only world, we lose opportunity to do things that give us peace. And that's maybe the crux of all of it, is the opportunity to feel better, to have pain control, to talk about things with your family, what you want, what you don't want, maybe look at what it looks like in your last days, if they are that, and if they're not, then you've made some plans that may be useful in the future. The psychosocial spiritual family is a big bucket that can be a lot of things. So pain's controlled, prognostic awareness in place, we've done some advanced care planning, which is where code status comes in, and we'll talk about that because that's really confusing too. And then what is keeping this person from peace? I haven't talked to my daughter in 30 years, and I can't think about what it looks like if I leave this world without talking to her. Or I I have 2 dogs and I gotta find a place for my dogs, or I gotta clean out my closet, or whatever people have to do that they're not doing, because if they admit that they need to do it, they admit that they're really sick. That can be a powerful thing, but all of those things are into it. And then the drama that comes with being sick and who's not telling who and who understands what, we are all neck deep in that too. So that's what palliative medicine does, is those 4 main tenets. So, questions about that. I'm gonna go back, because this is, so questions about what it is that palliative medicine does, can do, does do. Oh, hello.
I'll figure it out.
Okay.
Don't focus on me.
Okay. Pay no attention to the woman behind the curtain. So who's appropriate for palliative care referral? Palliative care, palliative medicine, sort of interchangeable. I think the biggest thing that you can start with is the idea of who needs help with symptom management. Uncontrolled pain in cancer, uncontrolled dyspnea in heart failure and COPD, sometimes delirium and distress in dementia. I'd say our biggest sort of group of people there is the pain, is cancer pain. Holy moly.
Sorry, Martini.
That's okay. I have to remember what I was going to say next. Oh, the idea, the prognostic awareness idea. So that you're up at the nurse's station being like, I don't think they know, I don't think they understand. Now, people may know more than they're sort of like showing or living in the moment. You know, people don't just walk around being like, hi, nice to meet you, I'm dying. But not right now, but like kind of, so just know I understand. Like, people don't do that. So they may know more than we think they know, but there's often times, I think, when it seems that they are making decisions that maybe they don't have the full understanding about our worries as their medical team. And so unclear advanced directives or advanced care planning in serious illness. You know, like the 85-year-old with 6 COPD exacerbations in the last 3 months who's still full code. That would be an opportunity for some cultivation of prognostic awareness and a family meeting. So again, along with attempts at curative care. Yeah. Oh, theoretically. Okay. So the sort of the crystallization is that palliative care and palliative medicine is and not or. It's not instead of. You like checking Facebook?
No. I think someone's trying to call it on life size, because we did make that an option. I'm just working.
It's under clinical icons.
Clinical icons?
Yeah.
Thank you.
Give me this next one. There you go. There you go. Okay. So there's a graphic.
We're multitasking.
Yeah, that's okay. So the upshot here is that it's a continuum of, here's like time 0. And so time 0 for this person, if we think about a case, is a stage 4 lung cancer. So a stage 4 non-small cell lung cancer. They actually did a study, gosh, it's like 9 years ago now, that showed early palliative care, and they defined early as more than 3 months before death. Early palliative care in stage 4 lung cancer actually had a survival benefit of 2 months. So people with palliative care lived 11 months, people without palliative care lived 9 months, and they had a better quality of life, and they had less interventions at the end of life. So time 0 for this person is at diagnosis of stage 4 lung cancer. We have a clinic in oncology, so we see people at Rocky Mountain, or at Northwest Oncology. We also have a clinic at Rocky Mountain Heart and Lung, so we see heart and lung patients. We don't have our own clinic, and so we're limited to those sort of 2 subsets right now. And we also work in Brennan House, and we have palliative medicine consults in other facilities. So top 4 diagnoses for serious illness, cancer, heart disease, cancer, CHF, COPD, and dementia. So we feel like we're covering at least some of those bases. But so this person at stage 1, they have stage 4 disease, but chemotherapy makes sense for them, as it does for a lot of people. We are not anti-chemotherapy for the record. Chemotherapy, radiation, often, frequently, very, very useful.
You were
and
the
safe
only
for
participant in the meeting room. Please wait when we got there.
So, but it's percentage, right? So in the beginning, a little bit of palliative care, a lot of curative attempts. As time goes on and as illness progresses, that shifts. And then at some point, because it's the United States, we shift altogether. And then bereavement care happens after dying. So again, it's a continuum of and not or.
So can you follow with hospice?
Yes, so one of the other things we do is we're the medical directors for Home Options Hospice. So I have had patients where I meet them 2 years before, I had one patient in particular that I'm thinking of, ovarian cancer, awful pain. We met her in like 2015, I want to say. Managed her pain, managed her bowel, she had some malignant bowel obstructions, we helped her through those. 3 grown kids, drama with her family back home. She had round after round of chemotherapy, which helped her. She lived 2 years with a really bad initial prognosis, and then we helped her inpatient, we helped her outpatient, family meetings with her husband alone, because he had to figure out how he was going to live without her. So he's part of our focus as well. And then when it was seen that she was progressing through chemotherapy, she came on hospice and we remained her doctors until she passed away. And passed away, there's just sort of like total side note. There's sort of ideas in the palliative care community that you're not supposed to say passed away, that you're only supposed to say died. But I don't know. I kind of think passed away is a reasonable,
Softer.
yeah, it's softer. I do not like expired. I'm just gonna say that for the record. I'm just gonna say that for the record, I do not like expired. So it's always too early to think about what we worry about until it's too late. So the right time is different for different people, but if you think it might be useful, it's rarely wrong to think about having palliative medicine involved. Yes.
You talked about how we do it in our country.
Yeah.
Are you seeing a big difference in other countries and what we could be doing, what we need to be pushing for?
So the question was, what does it look like around the world? So I did a little bit of training. I went overseas and did some training in Moldova, which is Eastern Europe, like former Soviet bloc. And I've looked into a little bit about how NHS does it in the UK, and I've looked into how Canada does it. And in general, and I won't speak specifically to those countries, but in general, the idea of palliative medicine is either not a thing at all, like they don't have it at all, and in Moldova in particular, only specialty oncologists could write for opiates. So family docs couldn't, nobody else could, and so they have like 4 oncologists, and so, I mean, they have more than that, but the need for pain control was enormous. So in some ways, we're doing better than some places. But what I think should happen is the idea of that cliff you have to jump off to say, now your hospice is not useful for the system, it's not useful for patients. So I would say we should have hospice type services, home nursing, expert care in the home, that 24-hour crisis management earlier in patients' course. So, and we should manage people's pain throughout their illness. We shouldn't like say, are you ready for hospice now? Okay, now you're gonna have pain control. Like, we should manage people's pain throughout their whole illness. And there's this idea that comfort measures only CMOs, like commence morphine overdose. And I feel like we just need to get away from that idea. Like, opiates were invented and put on this earth to control pain, and we need to control people's pain and have attention to their psychosocial, spiritual, pooping needs so much earlier in their illness. So I think that means palliative care earlier in their illness and palliative nursing earlier in their illness. So hospice, yes.
So for palliative care, they do not have the strict criteria that hospice, you have to have weight loss, you have
No.
to meet these.
No.
You can receive palliative care whenever the nursing team or the physicians feel appropriate.
There are, so the question was, are there regulations like there are for hospice? No, none. So CMS, Medicare, Medicaid doesn't say when I can call a cardiology consult in the same way that they're not saying what are the criteria for a palliative medicine consult. So it's no rules. It's great.
But it wouldn't necessarily cover
It is covered.
100% like.
It's a specialty.
like hospice.
Well, so what does it include? Right now, our palliative medicine is a physician or a nurse practitioner consult. It isn't care in the home. It isn't social work counseling, which it should be, but we don't have that. It isn't the care that hospice gives, which I think actually would be so much more beneficial so much earlier in people's course. Because we focus everything up here on the hill in the hospital, and people are at home and they can't get up here. And if we were able to meet them where they were and take care of them where they were, which is the benefits for hospice, but not make them jump off the cliff of choosing not to have more chemotherapy, I think people would do better. So that's the crux of it, I think, is that home nursing care that hospice nurses are amazing at. Why can't you have that if you're doing one more round of chemotherapy? Why can't you have that if you have palliative radiation? Well, because it's expensive, right? But
And I think people would be more open to jumping on that train and getting involved with palliative care without the H word, without hospice being attached to it.
yeah, that's true.
Because there is such a negative connotation.
Right. Yes. I tell people, they're like, everyone on hospice dies. Like, this is true. Well, that's actually not
Everyone
true.
on earth dies.
Right. And I say, yes, people who are on hospice die. However, they die way better than people that aren't. They don't suffer. They do die, but they don't suffer. So,
Some graduate.
and some graduate, yes. So I think about it like, I say hospice is a set of services, like physical therapy, like, other services that you have. Just because you choose this set of services, your path will be your path. What will be, will be. Hospice is not going to make you worse. They sometimes can make you better, but they don't affect your trajectory. Does that make sense? I used to have a really good analogy about it, like, and I'll come up with it. But just because you choose these services doesn't mean you will or won't die. It has nothing to do with that. It just means these things work best for you. And I wish we could detangle it from the not chemotherapy, not radiation part. So hospice is a defined set of services paid for by an insurance company. Most hospice, 80% plus, is paid for by Medicare, and so they set the rules. There's 24-hour on-call coverage, but it's not 24-hour bedside coverage. I think a lot of people say, let's go with hospice and, they're gonna move in with you and do everything. Now, I wish that would be the case. Now our hospice nurse in the audience is like, no, thank you. Because we expect patients, we expect families to go from like banker to nurse. You need to do all this bedside nursing for your dying family member, here you go. Anyway, that's a whole different rant, but it's a home care aide, it's a chaplain, it's a social worker, it's medication assessment and expert symptom management. I mean, hospice nurses operate in the field, in patients' homes, making assessments and communicating with me and my team, but I trust them to say, pain's not controlled, here's what he's taking, what should we do next? They operate very independently, and I trust them all, and they're all amazing at what they do. It is all that care is paid for by insurance, but it is not paid for if someone chooses to continue curative attempts. Hospice can also include inpatient hospice. If people's pain is not able to be managed at home, that's when we have people over at health center on inpatient hospice.
But I can be on hospice and get radiation to
No.
help treat pain?
No,
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 that would only
and-
be palliative.
not even if it's palliative radiation. And the reason that is all money. Hospice is paid X per day to provide all of the care related to that patient's terminal illness, and they cannot afford radiation. So, I think home options stretches things, because we're big enough we can massage things a little bit, but radiation's not part of that.
What about blood transfusions?
Sometimes, yeah. So the question was blood transfusions. And so I think we've advocated over time that truly it can be a comfort issue. It can help somebody feel better. And so blood transfusions are not completely off the table. IV fluids are not completely off the table. Now, it's always sort of a dance. It's always sort of a little bit of a like, we got to make the case that this helps you feel better. But those two things in particular are not off the table. Paracentesis, thoracentesis, those are trickier and harder, but not off the table. So trade-offs, increased services at home are paid for, disease-directed services are not paid for. And the VA actually pays much more under hospice than Medicare does. Private insurance is actually worse than Medicare often. They actually have sometimes a cap on their hospice benefits, like in a private insurance like Blue Cross Blue Shield or Allegiance or something like that. So this is where the certification of the 6-month prognosis comes in. So we have to say that based on these guidelines that we have, we would not be surprised if they died in 6 months. So some people say like they take that as sort of like a pronouncement, but I had a lady in Eureka who was on hospice for 2 years with pancreatic cancer, 0 treatment. She had a lot of heartburn, she said. But she got diagnosed super early. She had a strong family history. It was basically, 1 centimeter, and she was like not having it. So she lived for 2 years on hospice. People can graduate from hospice, especially COPDers or sometimes frail dementia, that increased nursing attention at home and attention to their symptoms and proactive management. They'll graduate. Hospice makes them better. I've had more than one person, all COPDers, say, I'd be dead by now if it wasn't for hospice. So, just wanted to bring it around that for a second. But it's true. I mean, they're amazing. So, hospice is appropriate. When is hospice appropriate? When the goals shift from attempts to cure to attention to comfort. And they fit the criteria. And that's tricky, and that's part of where we come in to help say, is this right, is this not right? So the crux of the decision is, do these services fit what you want? And when I talk to people about hospice, I don't walk in and say, hello, would you like some hospice? Because they're gonna say, no, I don't, because that means death, dying, and I don't wanna do that. I say, we talk about the services and we talk about what they want and what they don't want, and I say, what you want is called hospice. And they say, oh, okay, sometimes they're like, okay, so let's talk about code status. Very confusing. How we talk about it, what it means. These are just some of the options. I remember there used to be Comfort One when I first came here, that green card that you could have. I never really knew what that meant. A DNAR, do not attempt resuscitation. So what does all of it mean? I just want to say going palliative is not a thing. Because we think about going hospice is you are here in the curative track and you're like, nope, now I'm over here in the hospice track. That's perhaps going hospice. I'm doing this a lot, that's irritating. My oldest daughter did that to me when she learned how to do that. She's like, hello, Mom. I'm not allegedly your mom. But going palliative in that same way that you go off one train track and onto another train track in hospice is not really a thing, because palliative care is and not or. So essentially, in my mind, code status is 3 functional options. You're either full code, which is default for everyone, and that's a whole different set of conversations. DNR, with or without other restrictions. So that's DNR full medical, DNR limited, And I choose not to parse out intubate me, but don't resuscitate me, don't do CPR or shock me, because I think that's ludicrous. That being said, if there's a choice to intubate someone, for those COPDers that might want to be intubated but not shocked, I do think that you can do that, but I think that that decision is often slower rather than in the moment of calling a code. Not always, but sometimes. But I choose not to sort of parse that out because I think the population to whom that applies is small and often makes their wishes known. And so it confuses people if you give them a laundry list and they don't understand. So if you can say, if you give somebody a list and say, do you want shocks or medicine or tubes or, come on in girls. There's one more. So I think that's too confusing for general knowledge. I think the people for whom intubation but not cardioversion or CPR makes sense is small. And those people, I think, suss themselves out. So DNR with or without restrictions, and then comfort care, or comfort measures only, or however you want to parse that. To me, those are the three that make sense. Do you guys have thoughts or ideas or otherwise about how we think about code status? Yeah. There's and limited interventions is on the post form, but full medical is the way we talk about it in this hospital, and full medical sounds way better than limited interventions, but they're really kind of the same thing. So you need to make a decision before the moment your heart stops about what you want or what you don't want. Everything else you can make a decision on, or your surrogate decision maker can make a decision on. So that's what this is about. So advanced care planning, who's a medical POA, is a surrogate decision maker. So in Montana, your default surrogate decision maker is your spouse, legal spouse. Can't be common law. Common law actually has no power, has no rights, unless they're designated a medical decision maker. And then it goes down from there. It is a very simple form to designate a surrogate decision maker. Doesn't need to be notarized, it just needs to be witnessed. And unless you want your default to be your surrogate decision maker, you have to choose somebody else. And that form is important, but what's actually more important is the conversation around that form, and that's a whole different conversation too. So advanced directives are what you want or what you don't want. In Montana, it's a POLST, which is Provider Order for Life-Sustaining Treatment, which is super ironic because it's really Provider Order for Not Life-Sustaining Treatment, but I didn't know they wanted to say, the N didn't fit in there. Comfort One is an old one, so we don't really use that anymore. A living will to me is a lawyer document that lives in a folder in a file drawer somewhere that you pull out, and it's long and it's complicated. And to me, a POLST form is a do not plug me in document. So if my heart stops, do not attempt resuscitation, allow natural death. In that moment, it's green, it's short, it's clear. A living will is unplug me if I'm not getting better. A living will is plug me in because no one's going to find the form because it's in the thing and it's it's Tuesday at 9 o'clock at night and the lawyer's not there. So you're going to plug me in, but this says under what circumstances you unplug me. It's not who gets the Corvette when you die. That's a will, it's not a living will. So to me, there's really effectively two documents. A do not plug me in document or a plug me in but unplug me if I'm not getting better document. Both are important, both need a surrogate decision maker. So they asked me to talk some about the nursing part of taking care of people with serious illness. And you all know way more about that than I do because you're at the bedside in times that I'm not, and sort of communicating with people in a way I really, really respect but have no way of understanding or knowing. But I think what's important, and I talked to a couple different nurses to try and understand this for myself, is the question, that vulnerable moment when someone looks at you and says, so do you think I'm going to make it? Or is this okay, or am I okay, or is this going well? They're not asking us that question, because that's too heavy. They don't really want to know what we think, but they want to know someone who cares about them, who's spending much more time with them, and who's walked this road before. They want to know what you guys think. And I think about the idea of holding space. Like, what we want to do as human beings in that moment is be like, no, 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 everything's fine, you're going to be great. Everything's going to be perfect, and you're going to make it through this, and yeah, you're going to make it to that wedding in December, and you're going to see your kid grow up. And in your mind, you may be thinking, I'm not totally sure that that's true. And in that moment where someone asks you that question, it is a brave thing to say, I can understand why you'd be worried about that. That must be really hard. And just to not do the easy reassurance. And also not be able to fix it. I think that sometimes I struggle with not being able to fix stuff because I still want to do that. But I'm learning over and over and over doing this that it is so valuable just to sit with someone in the suck of it all and just say, this really sucks, and I wish this didn't suck, and I wish this wasn't happening for you, and I'm really sorry it is. And that if you give them the easy reassurance, for some people, it shuts them down. Then they're all alone in it. You know, if you can let them let it out and hear them and hold that sort of space around that question, that can be really powerful for their own ability to not feel all by themselves.
And establish trust.
Right.
Because if you offer the easy reassurance, they don't believe anything you say.
Because they know. I have very rarely told somebody a bad prognosis that didn't already know. Family doesn't know all the time, although they know more than they admit. But patients almost always know.
Well, and it gives them the opening to
Yeah.
share their fear instead of, oh, you'll be okay, then they feel like they can't say anything.
Right. And then they're like, well, am I wrong? Like, is everything that I'm feeling wrong? Or because that hope is so strong, you really don't want to believe what your body's telling you, or even what people are telling you. And then you feel like you have to do either or. You have to be black or you have to be white. You have to be hopeful or you have to be realistic. You either have to be like accepting or in denial. And in reality, people are both, all, neither. And we put judgment on it.
I pray with patients,
Mhm.
and it really does help when they're in that place. You know?
Yeah.
It's just, you just feel when you feel the presence of God in your life when you're with something so terminal. I think it just helps, just
Yeah.
to know that your nurse actually really is where you're at spiritually, and
Yeah.
it just helps.
Sees you. Like, to be really seen by another person, like in all the sort of messiness and the brokenness and the like suckiness of it all, for someone to just sit with you in it and see you and hold your, and see you and not walk away.
Yeah.
Like, see you and sit with you. Because some of us, all of us human beings, are freaked out by our own, some more than others, are freaked out by your own mortality. Like, death might be contagious. Like, if I go here with them, like somehow it's like tainted. She says I'm doing good. But, so, I think the nurse's ability in particular, because you guys are so bedside and so intimate with people, that I'm seeing you and I'm not running away. Like, it's okay. It's not okay. It sucks. But I'm still here.
You're not alone.
You're not alone. And you're admitting that you're worried is okay. Because I'm worried too. The concepts of hope and the concepts of worry are so, so powerful. that when I'm communicating with people, I don't walk in and I don't say, you have 3 months to live, get your affairs in order. That's pretty cold and wrong, like, I don't know. But I can say, I'm really hopeful that we can get you through this. I am hopeful we can make a difference in your pain. I'm hopeful we can treat this pneumonia. But I have to say I'm really worried because of this, 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 and this. And that communicates to people that I'm hopeful for them, but it allows you to communicate that you care for them and that you're worried that things might not go the way we want. So a couple resources. Get Palliative Care is the sort of consumer patient part of CAPC, the Center to Advance Palliative Care. We actually are members of the Center to Advance Palliative Care, and they have great education, pain management education, nausea education, nursing education. I think you can get CMEs for it, it's all online. Being Mortal is both a book and a documentary. It's by Atul Gawande, who's a doctor out of Harvard. He's a brilliant person and an amazing writer, but if you just Google Being Mortal PBS Frontline, it's a free hour-long documentary that you can watch where he goes through, I think it's 3 or 4 different patients and families, how people interact with terminal illness differently. So it's super fascinating, free. The book is also really, really good. I just started reading this next book. It's called A Beginner's Guide to the End, and it's written by a palliative care doctor out of San Francisco. He also has an amazing TED Talk. He's a triple amputee, and he's really cute too, so it's like not hard to watch. But he talks about his own sort of mortality, brush with death, I suppose, and then how he relates to his patients. So I'm not very far in this other one, but it's good. So Fast Facts is a resource out of the Medical College of Wisconsin, and they have 1-page summaries of, I think, hundreds now, palliative care and hospice issues. So from management of terminal delirium to opiate rotation to how to break bad news to how to deal with requests for hastened death, the black jelly bean. Amazing, searchable, a great resource. And there's an app too. Palliative care, there's an app for it now. So, thoughts, ideas, questions? This is the first time I've given this talk in particular, so if you can give Katie any feedback, good, bad, or otherwise.
I feel like maybe with First Floor, we have this opportunity with our surgeons where we feel like they should be consulting you guys sooner.
Yeah.
I don't know if there's anything that we can
That's tricky.
do.
Yeah, so the question is, how do we help surgeons see that we're and not or? I have thought a long time about motivators and drivers and where they're coming from and how we can partner with them, and I have a lot of empathy. I get to come in and have a very clear sort of set of goals about what I'm going to do, but they have to switch from one role of sort of a champion of hope to they see perhaps asking us to come see somebody as giving up that hope. Like they're the black and the white, and so I don't have to navigate that. Like I get to come in sort of as both always, but they have to go from all one, and they have to sort of, in some ways, admit that things might not go the way they want. And so I have a lot of sympathy for the role that they have to play. But the nitty-gritty question of you guys seeing someone who could benefit and how do we help them see, I don't know the answer. I think the answer is maybe making the case in a way that respects where the difficulties that they're up against.
Have you given a similar presentation to your peers or those?
I'm giving one for the benefits of early palliative care to the Committee on Cancer. But in some ways, like the patient who is in different stages of prognostic awareness, what you say and what they hear and believe are different. I think younger surgeons have a different relationship with palliative medicine. I think older surgeons are still very much in the black and white. I see that in oncology too. So I think, like all human beings, we have empathy and grace and work to have understanding for everybody and say, how do we work together to help people? I think it's easy to just like, oh, the oncologist never told them, and oh, the surgeon can't see it, but that's not true. They're people working to help their patients. But how do we maybe help them see we can help them too?
I had a couple of those conversations in previous roles where I could say like, they will help hold the conversational space for like advanced care planning, and because that was often not necessarily something, some of them were good at self-identifying, like that's maybe not a conversation I have time to have. I don't have an hour of my day to come and sit in this room with a family member and kind of have that conversation. So I would often say like, they can come and spend this time with the patient in the middle of the day when you're in surgery. Like I framed it like that often and just said like, they can hold that space a little bit.
And one of the luxuries we do have is that we have time. Like, I often joke that like nothing I do takes less than an hour. So, and that's expected of us, and so we have that luxury. But I think it's a process, like everything, of culture change, of us all understanding what we do and how we help each other and what's right for patients. So I feel like we started palliative medicine here in 2011 with an outpatient clinic in oncology. So we've come a long way in 8 years, and hopefully we keep, and I always had to explain, I started that clinic and it was constantly explaining to everybody what palliative care meant. And now I only have to explain to like 3/4 of the people what palliative care means. And so it's like, I told one of the hospitalists back then, I was like, Charlie Sharman, you guys probably know him. But I said, I'm taking the exam to be boarded in hospice and palliative medicine. And he said, is the answer always morphine? I said, no, it's not. I studied.
I read a book, and I don't know if it's How Doctors Think by Jerome Grootman.
Okay.
He does a book, and I haven't gotten it, but the book is good, The Anatomy of Hope.
Oh. There's a lot, and there's actually sort of, I feel like there's a cultural conversation happening about death and dying. There was an amazing book called When Breath Becomes Air, written by a neurosurgeon. Yes, that was interesting too. So there's a lot of, I think, thinking about it and talking about it. And baby boomers don't want to go the way their parents did. And they have a very healthy questioning of authority that perhaps the prior generation didn't. Which you can understand. Like if you came of age before penicillin and insulin, like we can do anything, and put a man on the moon. But the boomers, I think, have saw that didn't serve their parents and maybe want to do it differently.
A lot of nurses that I work with, there's a large gray area between calling a rapid response when a person is DNR full med. I feel like that should be an option because they're still full med. I mean, there's a certain point where you have to obviously not do anything.
Somebody.
Yeah, but
so, go ahead.
I was just gonna, like, what are your thoughts on
I think that speaks to the grayness of full med. I don't think that's unreasonable. Do they need BiPAP? Do they need suppressors? Do they need an ICU stay? To me, and this is different, I mean, I think people think about this differently. To me, DNR is one procedure. It is CPR. It is cardiopulmonary resuscitation when someone has lost a pulse. So to me, DNR is that one procedure. Everything else is fair game. People think about that differently. I've had ER docs call me and say, I sent my 80-year-old patient from Brendan House over who I think has pneumonia, and they're like, what do you want me to do with this DNR patient? And I'm like, well, I think that you should start some antibiotics. And you should maybe do a history and physical, and I recommend Zosyn and Vancouver. But don't code them, you know, like, do all those things, but if their heart stops, don't code them. So, in the grayer it gets, the more we can do short. Vapotherm is a pain in my, like, what is that? People can't leave the hospital, right? High flow oxygen, you can't leave the hospital. But people can be on it for weeks and weeks, like, where does that fit? What does that mean? And so, it's all, there's lots of gray area in it, but I don't think that's unreasonable, depending on the person, like where they draw those lines. But DNR is just, to me, one line.
That's where that conversation is so important, with the
Right.
patient and the family and the people making.
If you want to draw other lines, you got to draw other lines. But to me, DNR is hard stop.
And I don't think a lot of people understand that. I work in home health, and in a hospital, this person has a DNR. Okay, so when I do an admission in home health, we have to ask that question. And so I say, would you like us to resuscitate you? If, physical therapist is here and working with you, and all of a sudden your heart stops, and they go, oh yeah, I do.
So one way I think,
So I don't understand why.
well, and how people understand it and how the question's asked and what situation it's asked and who's in the room varies greatly. I ask it, the way I ask that question is, are there any medical procedures you do not want us to do? For example, some people say, I want everything to help me get better, but if my heart stops, don't shock my heart and don't put me on a breathing machine. And a lot of times people will say, yeah, I don't want that. But if you say resuscitate, what does that mean? You know what I mean? Like, what does that mean to them?
I don't think they understand.
Right, so that's why I ask it in that way. Like, I had one person where I asked, so I said something about tubes, and he had been up the yak and hadn't had a TB, and he had nasal cannula oxygen on. And he's like, well, this is okay, I'll take tubes. So what we say and what people understand is different. So how it's asked, I think matters. Do you want everything? Yes. Onions, peppers, I want everything. Do you want nothing? No, nothing is bad. So that's, I think palliative care comes in there too, because if the choice is everything or nothing, everything is better. But if the choice is, continued chemotherapy that's not working, or home with good pain control, I want home with good pain control. So, I'm respectful of your time, so thank you for coming. I hope it's helpful.
Thank you.